Hello everyone, it's Dr. P here again. Today I'm following up with my 5-part talk about 5 things every woman should know about a mammogram. Last time we talked about number 5, which was the importance of removing deodorant because it can look like breast cancer. And today we're going to quickly talk about number 4, which is why patients are called back from a screening mammogram. This is important because most of the explanations floating around out there are wrong. This is not by any means the patient's fault. In general, I think we as radiologists and physicians do a horrible job of explaining why we recall patients from a screening mammogram. So look, if we recall a patient from a screening mammogram, we send a lay letter to the patient. Basically, this letter says, there's something about your mammogram that requires evaluation. That's it. And we leave patients in the dark. Then we schedule an appointment a week out and we tell the patient, go sleep on it for a week. It's no wonder that not only does that cause anxiety, but it causes all kinds of crazy ideas to float around out there. Meanwhile, we send the actual report to the patient's doctor, which discusses why the patient is actually being recalled. I'm not so sure this is fair to the patient. I understand that there's a belief out there that patients won't understand the actual radiology report. And I understand the concept because medical information does require a lot of context, and without that context it can cause unnecessary anxiety or fear or just disinformation in general. But if we're going to send a generic lay letter, I think it's very important, it's our responsibility to explain the significance of callbacks and why they most commonly occur. So first, I'm going to talk about 4 major points. First, in general, a callback is not, is not because we suspect there is cancer, but because we need to confirm that an area is not cancer. That is by far the more common scenario. Yes, there are always areas where we do suspect cancer, but by and large, it's to confirm that it's not. Why would we need to do that? What people don't realize is that a mammogram is a very subjective screening test. It's often difficult to differentiate cancer from breast tissue. But if you think about it, breast cancer is just breast tissue that's behaving abnormally. So you can imagine, and it shouldn't be any surprise, that sometimes abnormally behaving breast tissue can be difficult to differentiate between regular normal behaving breast tissue. So that's the first thing. Remember, a callback is not because, in general, is not because we suspect there is cancer, but because we need to confirm that an area is not cancer. The second thing is callbacks occur 10% of the time, on average. There's an organization called the Breast Cancer Surveillance Consortium. They receive a grant from the National Cancer Institute. They record this data from a sample of radiologists. It's like the Nielsen ratings on TV where they monitor television sets across the US. They do the same thing with radiologists, and they record all the data. Most recently, I think they looked at between 1 and 2 million mammograms from 300 to 400 radiologists to gather how often we're recalling patients. In 2013, the recall rate was right around 10.6%. So it's important to remember, if you get a screening mammogram every year, beginning at age 40, by the time you're 60, you will have been recalled twice. So just because you're recalled doesn't necessarily mean it's a bad thing, that cancer's coming. It's just our way of interpreting your mammograms, and it happens 10.6% of the time. That's number 2. The third thing is, of those 10%, only a very tiny percentage actually turn out to be breast cancer. According to the same BCSC data, 4.4% of those turn out to be cancer within 1 year. So of course, we can't take chances with almost 5% of the population, but at the same time, 95% of the time, it turns out not to be cancer. So keep that into perspective if you're ever recalled for a screening mammogram. And the fourth thing, and this is really just kind of an educational point, so that if you're ever recalled for a screening mammogram, at least you know some of the terms, you know why it happens. I'm going to show you actual examples. There are 3 very common things that pop up in a mammogram that we need to get additional images for. In other words, the 4 views that we get don't give us enough information. We need to use another tool, ultrasound, other pictures, something to give us an idea of what's going on in the breast. Those 3 things are masses, calcifications, and focal asymmetries or asymmetries. And I'm going to explain those three and show them on here for you. The first one, masses. A mass is, it's a technical term for us. I mean, most people have an intuitive idea about what it is. This could be solid, it could be a collection of fluid. All of those are classified as masses. And let me show you an example. Here is a recent screening mammogram that I interpreted, and I know what this is now because we have additional information, but had I not had all that additional information, there is no way to tell this nice little round ball. I don't know how well you can see it in the camera, but this turned out to be a cyst. But a very small percentage of the time, cancer will look identical. There's no way from a screening mammogram for us to tell. So what do? We bring the patient back, and usually that means we get an ultrasound to make sure that it's fluid. 94+% of the time, according to some statistics, this turns out to just be a cyst. Nothing to worry about. A lot of anxiety, but it's our way of keeping you safe. So that's a mass. The second one, let me pull it up here for you real quick. That scenario that we run into is calcifications. Now, calcifications occur in the breast normally, no big deal. They occur in soft tissues, especially in the breast. Most of the time it's benign, has nothing to do with what you eat, but they show up. Like I said, most of the time benign. A very small percentage of the time it can be indicative of early breast cancer. And so we have to look at the shape of them. Now, this is a standard screening mammogram. You can see right here, just one standard view, and we see this calcium. Now, we know what the shapes of these are, but they're these fine little specks that is basically beyond the resolution of our imaging detector at this on this picture. So we have to get a special dedicated magnification view to look at the shapes of these calcifications to determine whether there's something to worry about, something to watch, or nothing at all. That's the second common scenario. And the last one, and of course there are others, but these are some of the more common ones, is what we call an asymmetry or focal asymmetry. And I've pulled one up here for you. This is also a recent screening mammogram that I read. Here's an example. All this white stuff in here, normal breast tissue, same thing. This is probably just an island of normal breast tissue. Maybe it's overlapping breast tissue. We don't know 100% for sure, but the problem is cancer could look just like this. So again, here's a scenario where we'll bring you back, take a couple extra pictures. Now in this case, it might be an ultrasound and additional imaging. It might be just additional imaging. It all depends. But these scenarios come up, and again, on average, about 10% of the time. So this will come up, and we'll have to take another closer look. But I hope this, in conclusion, starts to give you an idea of why we perform callbacks, what some of the terminology is, how often they occur, and put it into perspective that, get it taken care of, take a look, but don't be unnecessarily alarmed. And I hope that helps. Thanks a lot. Next time we'll talk about number 3.